Thank you so much for having me this morning, and thank you for being patient with all the technical issues. So my name is Alli Ward. I'm the Director of Membership at NORD, the National Organization of Rare Disorders. I'm excited to be here with you all this morning for the Superficial Siderosis Research Alliance Symposium. I have spent the last 15 years working in the nonprofit advocacy work, and the last 5 years specifically in the rare disease space and working organizations and communities like yourselves. I am honored to have the opportunity to work with organizations such as yours. And today I will be sharing more about NORD and the work that we do. All that we do at NORD is grounded in our mission of improving the health and well-being of people with rare diseases by driving advances in care, research, and policy. There's often questions about what makes a disease or disorder rare. A rare disease is defined as affecting fewer than 200,000 people in the US. There are more than 10,000 known rare diseases, and more than 30 million Americans live with a rare disease. So while many rare diseases are a small number of people that are affected, when you group together all those affected by rare diseases, you have a large amount of people that are presented at least in the US as well as the world. And this is what NORD is here for. NORD really wants to support and give a voice to everyone that has a rare disease. NORD was founded in 1983 by parents and grassroots advocates who successfully secured legislation to incentivize companies to develop rare disease treatments, and we formed the Orphan Drug Act. We are a national organization and a steadfast partner for the community. We connect caregivers, patients, advocates, physicians, researchers, industry, and regulatory leaders to each other. We are independent and we're nonpartisan. We really want to work on the behalf of the care of the patients and the community. And we are a mission-based nonprofit. All of NORD's work falls into 4 main pillars: community, care, research, and policy. The community pillar is where I'm representing today. Member organizations are the backbone of NORD, and we currently have over 350 nonprofit organizations, such as the Research Alliance, that are a membership of NORD. Together, we learn from each other, we support each other, and we combine our voices for rare disease awareness. Each year, organizations form this community, and we have a shared purpose. Our second pillar is care. And the first step towards hope and action and progress is for our patients and caregivers. We offer resources to support every step of the journey. And we have the Rare Care Patient Assistance Program. And last year, NORD provided millions of dollars in financial assistance. And just a little 2024 by the numbers. We had $24 million in financial support to 6,450 individuals. These were copays and insurance premiums and medications, travel to treatment, things that we can help tangibly do. The NORD Patient Services team engaged with nearly 135,000 callers and emailers throughout 2024. They are there every day to answer questions and provide support. Our third pillar is research. We work hard to accelerate and advance innovation for rare disease treatment and care through research grants, studies, patient registries, the Centers of Excellence networks, and partnerships. And we do have the I Am Rare program, which is a NORD-hosted registry program run by our member organizations. And our last pillar is policy. And we advocate on a federal and state level supporting the needs of rare diseases. Most recently, we have been advocating for Medicaid, inclusion of rare disease support in the budget, talking about the Affordable Care Act, and we have cultivated a network of grassroots advocates, not just organizations, but individual people that speak out on a state and federal level. And I just want to take a minute to talk about what being a NORD member is. The Superficial Siderosis Research Alliance has been a member of NORD for a couple years. And we work with our members. So we have over 350 organizations. These are small organizations that may have just started. These are organizations that have been members for over 20 years. These are organizations that are staff-led. And these organizations get to learn from each other. So the membership team, made up of 5 individuals, works with the member organization's staff, board, and volunteers to better serve the community. So some of the things that we offer, that we work with you and want to work more with, is peer support and networking. So if you have a question on, even on planning an event and what are some details I need to work on, you can go onto our Facebook page and ask questions of other organizations. We have networking events. We have our annual conference where you can come and learn on what's going on in the rare disease space. We have support and resources on capacity building, fundraising, board management, volunteer management. New this year, we have an advocacy training for staff and community members of people that do want to go and talk to their policy makers and talk about what's important to them in the policy space, advocacy space. And we have medical education and outreach, and we offer information on research support. One thing that my team really likes to say is our team is your team. Many organizations are like yourselves that are very small, and the community can be small, and you're working on taking care of yourself and your families, and the Research Alliance is serving many of those needs. Well, our team is your team. We're here to help you in advance your mission for your community. That is all it for me today. It was an honor to join you. I'm looking forward.
We're going to start now. I'm going to introduce myself, Kyle Dempsey. I'm president and founder of the SSRA. We founded this organization 6 years ago. My partner, Rory, is in the back. She's the vice president and executive director. We have a great lineup of speakers today. We are starting a little bit late, so don't feel like you have to make up time because we want to hear all of the information you have. So thank you very much. We already went over housekeeping. Please feel free to use bathrooms as needed. Also, the NORD presentation that you just heard, we are actively looking for a liaison to be the SSRA liaison to NORD. They have regular meetings and they're a great resource, and if we can use them more for our advantages, it'd be great. So if you would like a role like that, it can be whatever you want because we do not have someone in that role right now, but you would be working with myself and Rory as a liaison to NORD. They have many meetings and we can learn from them. So if that's something you'd be interested in, please see myself or Rory before you leave today or tomorrow. With that, without anything further ado, we're going to get with our first speaker, and very, very excited to have Professor David Werring come up here and speak on the role of multidisciplinary care in superficial siderosis. So here he is. Thank you very much.
Thank you very much, Kyle, and thank you to the whole team for making me feel so welcome here in Boston. And it's wonderful to be having the honor of being the first speaker in this session. So I'm David Werring. I'm a neurologist in London at a hospital called the National Hospital for Neurology. And I'm going to be talking you through the service that we've set up over probably the last 10 to 15 years since I first saw a person with this condition and knew very little about it. similar story to Professor Levy, that I was asked to see a patient, and it was a disease I'd never heard of, didn't know anything about it. So we set about trying to learn as much as we could, and also bringing patients together so that we could learn about the disease and also begin to set up a service. So I'm going to skip through my declarations. None of them are really relevant to this, except the first one, which is we're doing a research project on quantitative susceptibility mapping, which Susanna is going to be talking about tomorrow. So this is my hospital. It's an old hospital. It's a brain hospital, neurology hospital. And this is where we do the multidisciplinary team working. If anyone's really interested, there is an entire book about the history there published by Cambridge University Press, but I doubt if any of you are going to be rushing out to buy that. But it's a very interesting place to visit if you're interested in neurology, because it's one of the first neurology hospitals in the world. So this is the structure of my talk. I'm going to very briefly give some background, and Professor Levy is going to be talking about this later on this morning, so I'm going to be deliberately very brief, and then maybe he'll be able to build on that and give more information. I thought it was a good idea just to introduce the topic before I get straight into the multidisciplinary team working. Also, before we get into the team, I'm going to say a few words on just how much impact this disease can have on a very great number of health domains, as many of you in the audience will be all too aware. So I'll touch on some research that we've been involved in looking at quality of life and various symptoms of siderosis. And then I'll tell you about the team that we've set up, the multidisciplinary care pathway. And then I'll sum up and give some future perspectives. And I'm very much looking forward to learning from other people here who have been seeing people with siderosis and setting up services around the world. I think we've got a lot to learn from each other. So let's start with the background. If you are interested in the topic, this is a review that we published about 3 years ago now, but this does go through quite a bit of the material that'll be in my talk. So if you want more detail, this, I believe it should be freely available online from a journal called Practical Neurology. So as you all know, sideros is from the Greek word, siderosis comes from the Greek word sideros, meaning iron. And you all know that it's to do with the deposition of blood breakdown products in this compound known as hemosiderin over the surface of tissues within the nervous system. And that can be the brain, the cerebellum, and the spinal cord. And the terminology is confusing, actually. And the siderosis can be in different areas of the brain. And one classification that we have is we can say, is it predominantly infratentorial? And the tentorium is a membrane above the cerebellum. So infratentorial means low down, basically the cerebellum and what we call the posterior fossa. Or supratentorial, which is higher up in the brain. And today we're interested in an entity that's become known as infratentorial superficial siderosis. And that is because most of the iron deposition as hemosiderin is low down in the brain, particularly in the cerebellum. And then we further subclassified it into type 1, which is what the people in the room here, I think, are most interested in. We call this classical because it was described over 100 years ago. And then type 2 is where there is a single bleeding event within the brain, and it leaves a kind of a scar with the bleeding that's happened. What you're all interested in is the type 1, which is a very slow type of bleed into the spinal fluid over many years. And I've got to be careful not to get into too much detail here, because Michael's going to talk about this later on. Just a quick word, how rare is siderosis? So we took a look at a project called the UK Biobank, which recruited 500,000 people in the UK at random. And of those, 100,000 or so have had an MRI scan. And what we did, or what I should say, Natallia Kharytaniuk, who's also going to be speaking next, she looked at 10,000 of these scans to see how many people had siderosis in the community. And what we found is that it was around 1 in 2,000 people within the UK had evidence of siderosis. And it was always in the cerebellum, the superior cerebellar vermis. So for comparison, so siderosis is 48.5 per 100,000. And motor neuron disease, ALS, is between 1 and 10 per 100,000. So I just want to touch on this, that maybe it isn't actually as rare as we think it might be. Okay, I'm not going to go through this because I've already mentioned it, and Michael will tell you all about this. I will just show you a picture, though. So this is where the siderosis pretty much always begins. It's an area called the superior cerebellar vermis at the back of the brain. This is an axial MRI, so it's taken that way. And this is a type 1 classical siderosis. And this is what I call type 2 siderosis, where there's been a bleed. This was from an intracerebral hemorrhage, and it's left some kind of hemosiderin staining here in the fourth ventricle and around the bottom of the brainstem. But this is a stable kind of situation. It's non-progressive, and that's different to the type 1 classical siderosis that you all know about. Again, I think I'm going to skip through this. Michael's going to tell you all about this, but essentially, almost all cases of siderosis are due to dural problems. The dura is the membrane around the brain and the spine, and it's pretty much always a problem with the dura, most commonly trauma or neurosurgery in the past, but also ectasia, and also a long list of potential types of brain tumor that can cause siderosis. But again, I've got to skip through because I want Michael to tell you all about this later on. And just finally, it is confusing because you get the siderosis in the supratentorial areas up here as well as infratentorially. So although we call it infratentorial, it actually extends further north up into the brain. And this is a typical extra-arachnoid collection, and that's in axial cross-section. And this is a pseudomeningocele at the back of the brain after surgery. Okay. So I hope that will set the scene for Michael will tell you with great expertise and knowledge later on. So what are the symptoms of siderosis? You will be all too aware of these problems. Almost all the people that I've seen with siderosis have hearing loss as the earliest feature. And this can occur a long time before the condition is diagnosed, as many of you may have experienced. The next most common problem is balance problems, then what we call myelopathy, which is a problem with the spine, it can cause stiffness and difficulty with mobility. But more recently, we understand that cognition can be involved in siderosis, and we also know that bladder and bowel can be involved. And there's a list of things here. And I should say I'm very happy to share these slides if it'll be helpful to anyone after the meeting. So what about quality of life? What is the impact of this disease? And Natallia, who's the next speaker, did an online survey of 50 people with infratentorial siderosis. Some of you may have even done the survey. It was mainly people from the UK and from the United States. And we wanted to assess health-related quality of life in this condition, which had not been done to the best of our knowledge. And of course, this is really important. If you're going to set up a service, you need to know what are the issues that that service needs to look at. So what we used was something called the HUI3, and this was, Natallia found this when doing a literature search of instruments. And this is really quite a useful potential marker because it includes hearing complaints, and we know that this is a pivotal feature of siderosis. Many of you may have heard of the EQ5D, which is a very well-known instrument used a lot in health services, particularly the UK, for health economic evaluations. And we looked at these quality of life measures in people with siderosis to see what was the burden of this disease. Before I get into that, I'm just going to say one of the things we noted was there was a long interval between the event that may have caused the siderosis, be that a spinal operation or a posterior fossa operation or trauma, about 20 years between the event and the diagnosis, and then about 10 years until the hearing symptoms, and then another 10 years before diagnosis of the condition. So this is an obvious area where we need to improve awareness so that we can diagnose the condition earlier. But the main finding was that we found that basically it has a huge impact on quality of life. These are scores, the lower the score, the worse the quality of life. And I'm just going to briefly tell you that for someone who's had a stroke, a comparable figure would be 0.52. And we can see that in siderosis, it's around 0.64. So it's comparable to that of stroke or even motor neuron disease, actually. And the most frequently affected domains were hearing and pain for the HUI3, and then mobility and pain for the EQ5D. And we found some association between how long the disease had been going on with the HUI3 but not the EQ5D. And this is kind of maybe gives this instrument a little bit more face validity in that it's got a relationship to the length of a disease. And I'm going to skip over these. You can look at these if you're interested in the publication, but these were the top domains, was hearing and pain, and this was the HUI3, the hearing one. And then the EQ5D, we've got mobility followed by pain, if we look at moderate to severe problems. Just to say, cognition is something that we've investigated, and we found in 16 people who had really detailed analysis, half of them had cognitive difficulties, particularly with executive problems. And you may not be surprised to learn that we also found evidence of mood problems, anxiety and depression, and we showed widespread MRI involvement. So this is not considered traditionally to be a key feature of the disease, but I think it's so common that probably this is part of the condition. Okay, so now just to wrap up, I'm going to talk about the multidisciplinary team and the care pathway that we've set up at Queen Square. So these are the members of our team. So we have neurology, we have neuroradiology. This is people who are experts in diagnosis based on various forms of neuroimaging studies. Neurosurgery, and this is important because we may be looking at whether some of these dural problems can be repaired with neurosurgery. Neuro-otology or audiovestibular medicine, this is absolutely critical because hearing is, as you all know, is a core part of the disorder. Hematology, this is really important for monitoring some of the drugs that we might use, like deferoprone, and we're going to hear about this later on this morning. Neuropsychology, for those cognitive mood disorders that I just mentioned. Neurophysiotherapy, absolutely critical, and again, I think we're going to be hearing about some rehabilitation later on during the session. And then finally, uroneurology, and also this would include experts in bowel and autonomic problems. Something that we're increasingly aware is a serious problem, but it's never been properly sort of quantified or looked at as far as I'm aware. So this is a little bit difficult to see. I'm very happy to share it, but this is our pathway. And we set this up in order to standardize the way in which people were evaluated, because we were getting a lot of decisions were made where it looked as though you were getting a different decision depending on who was making the decision, and practice was not standardized. So we set this up to give us a rational diagnostic pathway. And in addition to MRI of the brain, we also use CT myelography to localize the leak. And we actually use CSF studies quite a lot for diagnosis and monitoring, which is something that might be different to other people's practice. So we're looking for evidence that there is an ongoing leak, because you can measure things in the CSF. You can measure a compound called ferritin that many of you will know about, which is a protein that is upregulated when there's been bleeding. And we can measure the red cells, and we can also measure the pigments that develop from breakdown called xanthochromia. So we use this quite a lot, but I'm looking forward to hearing about other services that and see what role they think CSF should play in this condition. But when we're thinking about going for kind of an invasive process like a neurosurgical operation or even a drug like deferoprone, we tend to, in our pathway, like to see evidence of active bleeding before we offer these kind of treatments. So, as I said, I'm happy to offer that, to provide the document if it's helpful to anyone afterwards. And we have a patient leaflet here. It's very simple, just explaining what the disease is for our hospital. So these are the components, the 5 components. Get the right diagnosis and the right classification. Because if it's a type 2 siderosis, for example, then it would not be rational to offer deferoprone because it's not a progressive disease. We like to see ongoing bleeding in the CSF before we consider any invasive treatments. We may consider dural repair if it's technically feasible with an acceptable risk balance. And Walter is going to tell us all about this later on. We would consider deferoprone in certain cases. I expect we're going to go through some of the evidence for this drug. I think it's an important consideration. but we have to accept the level of evidence currently is limited for this drug. And one of our jobs, hopefully, is going to be to collect some better evidence for this. But we do certainly offer it to people that are having progressive symptoms. And then the monitoring, and this should not be underestimated because this is not a benign drug necessarily. It's critical that you have proper monitoring in place. And then all the way through this pathway, we've got to always think about supportive care. And you could make the argument this is actually the most important part of the care, is the neurootology support, which may include cochlear implantation as well as other forms of rehabilitation. Natallia is going to talk about that shortly, and physiotherapy, psychology, neurourology. So these are the roles of the people in the team. So the neurologist, of course, has got to get the right diagnosis. We've got to accurately assess all those complex impairments. We've got to think about the optimal treatment direction and have overall coordination of the care. And then we have neuroradiology for rational investigation, neurosurgery for the treatable targets for neurosurgical intervention, neurootology for hearing, balance, and rehabilitation, but also cochlear implantation, hematology, and neuropsychology. So hopefully this is setting the scene quite well for some of the talks that are going to be coming up. So just to summarize, what have we done as this team? So it actually, one of the great advantages of a multidisciplinary team is you collect all the people that are being referred to the hospital. So we discuss every single patient who's referred. And this allows you then to make observations about the condition and to learn more about the condition. So we've learned about the prevalence, we've learned about the quality of life, we've learned about cognition. And I didn't mention this, but we've also looked at olfactory. So this is smell problems. And everyone that we evaluated had some problems with olfaction, with smell. And in 60% it was moderate to severe. This is our paper that we wrote on this. So it has a great advantage of allowing research. What do we actually do? Well, we meet virtually every 6 to 8 weeks. Most of us are doing this in our own time without any sort of form of reimbursement. We're doing it because we want to help these patients. We've assessed 132 people from all over the UK. We've offered chelation to 26 people, and there have been 23 neurosurgical repairs, and 11 people have had cochlear implantation. And we're going to be looking at the data very carefully of these people who've had intervention. So the rational treatments, as I've mentioned, are to repair the defect or to offer chelation therapy. And this is an example. You may just about be able to see that little hole there in the dura, which has then been fixed. This is the leak that the neuroradiologist identified with a CT myelogram. This is a cross-sectional CT myelogram. And the contrast is clearly leaking out at this very focal point. This is the hole that you can see, and this is when it's been repaired. And we're working on how do we monitor the success of a neurosurgical procedure. And one of the things we've done is to look at proteins in the CSF, the cerebrospinal fluid, and ferritin is upregulated probably for several months after a bleed. And what we're hoping to see is normalization. I've put in green the ones where we've had evidence of improvement, and this is in green where we've had evidence of improvement of the red cells. The other thing just to note is that it can take a long time for these things to become normal, sort of a year or more sometimes for these to normalize. So I'm very interested to learn what other people are doing to monitor this kind of intervention. Clinically, it's very difficult to know, isn't it? Because you don't have a control for what would have happened without the intervention. But this is one of the ways where we think it might be a useful way to monitor the technical success of the procedure. But I'm very much looking forward to see what Walter's going to tell us a little bit later on. And we don't yet have data on the clinical benefits of dural repairs. And this is going to be a big challenge with this disease because it can be a slowly progressive condition, and it's going to take time to really understand the benefits of these interventions. Okay, deferriprone, just a word to say that the results are mixed. If we look at all the studies, Natallia did this systematic review of the literature. You can see some people appear to improve, but some people also appear to get worse. Some people appear to be stable. Michael and I have been talking with Rory and others about a randomized trial of this drug for a very long time. Whether we'll manage to get it funded, who knows? It's going to be a difficult trial to do, But I think it's important that we try and get really good quality evidence for this drug. Okay, so that's all I have to say today. I've covered the fact that it may be a not so rare disease, has a range of causes, but all with these shared mechanisms and a distinct syndrome. So we recognize it now. It has a major impact on multiple aspects of health and quality of life, and it clearly requires a multidisciplinary approach, as I've outlined, because it's so complex and various. Future perspectives. So what do we need? And we'll be talking about the research agenda tomorrow. I think we still don't really have a good natural history cohort study to know what is the natural history. Why do some people progress more than others? Some people can be very, very stable. Some people can progress very quickly. I don't think we understand this. We need validated rating scales and imaging or laboratory biomarkers to diagnose and monitor the condition. And we need to know that they're measuring important aspects of the disease that are important to people with the condition and that are going to allow us to effectively test treatments. We do need controlled trials of treatments, I think, and that probably includes deferriprone. And we need equitable access to multidisciplinary care pathways. And it's been a struggle to keep our team going, to keep everyone available, because it involves such a lot of professionals and a lot of time and a lot of coordination. So I should acknowledge Natallia's incredible help in coordinating this for us over the last few years. So this is our team. These are the best photos I could find. That's our neuroradiologist with his funny glasses so that he can see the scans. This is our neuropsychologist, and this is hematology. This is Parag, who's the neurosurgeon, and Simon, who's another neurologist. He sees a lot of people with this condition, and we work closely together. And Natallia, you're going to hear from very shortly. So once again, a little bit of further reading, if you're interested in having a look. And I'll acknowledge the team again. I'll acknowledge the funding from the Biomedical Research Centre, who funded Natallia's PhD, in which a lot of this work was done. And particularly, of course, the patients and the families who've supported our research and allowed us to learn a little bit more about this condition over the last decade or so. And I thank you for your attention.
Thank you very much, Professor Werring. I just want to make a couple comments. Thank you again. The SSRA supports a study for deferriprone. Also, we support the natural history study. We're just going to need funding someday, but thank you very much for mentioning those two items. Also, people have asked why I'm wearing this jacket. So this is a rare disease jacket, although we found out we're not so rare here today. So this is the galloping question. So if you hear a gallop, what do you expect? A horse? But maybe sometimes it's a zebra. Also, everything will be available that's presented here today on our YouTube channel, so don't feel like you have to take notes on everything. But thank you for Professor Werring for sharing that you can also get those resources at other places, but we'll also have this all up with closed captioning, right, Rory? We'll have closed captioning. All right, without further ado, again, you don't want to listen to me. Dr. Natallia is going to speak next, and she's kind of already been introduced, so I'll walk away. Thank you.
Thank you, Kyle. Good morning, everyone. I just need to get this one going. Oh. Do I need to do something, or? I don't know. Well, yes, that's me. Thank you very much. I just want to say fantastic. This is a fantastic meeting, and a massive thank you to the organizers for this opportunity to be with you today and to present some of my research as part of this talk. I'll be speaking about the hearing and balance function in patients or individuals with superficial siderosis. All right. Let's see. Okay, so without before going ahead, I would like to acknowledge the funders, the National Institute for Health and Care Research at the University College London Hospital's Biomedical Research Centre, and additional support for the studies was provided by the Bernese MBBS Research Trust and Health Utilities Incorporated. So I'm not going to talk about the need for research into superficial siderosis. I think we all very much know that there is a lot of unknowns. And at the time when I was starting the PhD, about 300 cases were described in the scientific literature. And in the UK, the largest cohort of patients described with superficial siderosis was by Professor Werring. They focused on the radiological findings and put together a diagnostic criteria for this condition. But interestingly, because hearing imbalance is so prevalent, or impairment of hearing imbalance is so prevalent in superficial siderosis, but there were very, very few reports of audiological and vestibular findings in this condition, at least when I started my PhD, and they were limited in also in the number of patients involved. Interestingly, all audiological assessments were described, did include pure tone audiometry, which described the hearing loss in superficial siderosis as sensory neural and downsloping configuration. This is key slope, sometimes we refer to it as that. And it has been likened to the age-related hearing loss pattern, probably also because a lot of the patients would present in their second half of life with hearing loss, and anecdotally and also from evidence in the scientific reports, they have been dismissed with age-related hearing loss only to come back a few years later with much more significant deterioration in their hearing thresholds. Now, other tests were also done, but they were quite heterogeneous in what was done and what was reported. So it was very difficult to figure out where exactly the problem was lying. And interestingly, no reports of central auditory involvement was done at the time. So we quickly fixed that with a case report. A similar picture was for vestibular function report. So we had a mixed test battery and also mixed involvement in the results. So peripheral and central vestibular pathway involvement, meaning anything from Scarpa's ganglion upwards was referred to central or is referred to central, and peripheral it refers to the dysfunction of the end organs or the distal vestibular pathway. So we set out to look at the characteristics of the hearing imbalance function in our cohort of patients with superficial siderosis, and also to try to identify the likely affected segments of the auditory and vestibular pathways. So we did predominantly a retrospective data review. I did manage to put together a research project for prospective study. We looked at the patients' data who had radiological diagnosis of superficial siderosis and underwent hearing and balance tests at our unit. Unfortunately, with COVID, I couldn't recruit large numbers of prospective study patients, so we focused on the retrospective data review. So when we talk about sensory neural hearing loss, we need to actually be a little bit more specific, at least from the site of lesion point of view. So what happens is that essentially we need to rule out the conductive hearing loss as a cause for the hearing loss, that is involvement of the middle ear or the blockage in the outer ear for various reasons, which would interfere with the conductive component of the sound to the cochlea. And looking at the sensory neural hearing loss, the divide is that of cochlea, that is or I should be more specific probably, Involvement of the outer hair cells within the cochlea is referred to as the sensory hearing loss, and the retrocochlea is the neuronal component, so that is the inner hair cells, the synapses, and the auditory nerve involvement. But also, we must differentiate between central and peripheral hearing loss. So central involving the brainstem structure, as you can see here, brainstem or more proximal, so the auditory cortex, and peripheral, everything else towards the end organ. And the other challenge is that we need to consider different parts of the pathway with different tests so that we have a continuous representation of the results of the auditory pathway. A similar picture is for the vestibular assessment, so we have this anatomical division into peripheral and central components, which, as I mentioned, divided by the Scarpa's ganglion over here, and the central projections are quite complex, and for the remit of this talk, I'm not going to go through them. I will refer to them as multi-system vestibular network. And similarly also with regards to the testing, we need to be mindful as to what tests to include to have a good representation of the entire vestibular pathway. So in the given period of the study, we had 96 patients diagnosed with superficial siderosis. Of those, almost half had hearing tests with us, and the final number was 39 patients whose data we reviewed. So looking at the age at the time of the test, so most patients, or at least the mean age was 50, and the disease duration was just over the 2 decades. Now, this is quite a busy slide, and I apologize for the busyness of it. But this was preliminary data I presented in 2020 and 22 patients of ours. We see pure tone audiograms, which are based on age and also on sex for the normative data for England. And I plotted against these data our patients' pure tone audiograms for average of both ears. And we see that the 5th centile, with the best centile to the 95th centile, the worst centile, were the normative data in the gray squiggly lines. And what we can see that the majority of patients actually had their hearing in quite low centiles, or even worse than the aged matched and sex matched norms. So we were unfortunately very heterogeneous in our assessment of a hearing pathway for patients with superficial siderosis. Just a quick breakdown of the results overall. And when we did central auditory tests for some of the patients, we see that 3/4 actually had some involvement of the central auditory pathway, and this was corroborated by a more specialized test, listening specialized neurosynthesis test, with 80% being abnormal. So looking at the site of lesion, so we see that the majority of patients would have a retrocochlear involvement with or without cochlear involvement, followed by cochlear involvement with or without retrocochlear involvement. But interestingly, what we could see is about 3 patients actually had normal hearing assessments, and that included pure tone audiometry and 1 other test, not excluding tympanometry. So tympanometry would have been done anyway. So pure tone audiometry and other hearing assessment test. Similar findings for vestibular assessment. So the demographic parameters was quite similar. Also heterogeneous approach to the assessment of the vestibular pathway in our patients, but as you can see, most patients had oculomotor assessment, so video nystagmography or electronystagmography. But again, universally across all of them, the majority had abnormal findings. Looking at, in a more granular way, at the oculomotor finding, what we found is that the The smooth pursuit abnormalities were the most common finding, and smooth pursuit is assessed by asking the patient to follow a slowly moving object with just their eyes without moving the head. And we're looking for any interrupted movement in the smooth pursuit. It is generated by a complex network, the central vestibular network that I've referred to in my previous slide. So that would identify involvement of the central involvement of the vestibular system. And the second most common findings were that of saccades, and saccades are assessed by asking the patients to quickly gaze or alternate the gaze between two objects horizontally and vertically, and what we're looking for is a reduction in the velocity or the speed of how quickly they move the eyes, or are they overshooting the target, are they undershooting the target, or are they slow to initiate the eye movement. And then involvement of saccades or abnormalities in the saccade movement would tell us that there is an involvement of either vestibular cerebellum or a brainstem vestibular nuclei or a combination thereof. And again, that signifies a central vestibular pathway involvement. So looking at the site of lesion, again, we see central involvement with bilateral peripheral involvement was the majority of patients who had this finding. This was followed by central-only involvement, and overall we see the common denominator is that the central or vestibular pathway was involved in 74, so almost 3/4 of our patients. Again, interestingly, some patients had normal findings of vestibular assessment. However, when we looked at the vestibular patients' MRI findings, we see that the superior verbis and cerebellar folia, which is the cerebellum, were universally involved, and they are here schematically represented with or without brainstem involvement and different parts of the brainstem. So moving on to my next study, and this one is a very brief study just to discuss the auditory profile of individuals with infratentorial superficial siderosis, because we need to really figure out as to how different this the hearing loss in superficial siderosis is from that of age-related hearing loss. So we actually used questionnaires to assess this, and we know that questionnaires or specific patient-reported outcome measures, as we refer to here, they have been used in the past for in a variety of patient groups with great results. So we aim to compare the auditory profile using the hearing-specific questionnaires in individuals with superficial siderosis versus those who had age-related hearing loss. And we wanted to attempt to identify any distinguishing features. It was an anonymous online survey, and we ran it during the pandemic. We got the ethics approval just before the lockdown in the UK, which was very useful. So at least we had something going on during the pandemic years. Okay. So these are the 4 questionnaires that we included in the study that were hearing specific, and one of them was on tinnitus. The characteristics of the questionnaires are here, and you can see that we have 47 individuals with superficial siderosis whose data we analyzed versus 30 in the age-related hearing loss group. However, comparing the age self-reported hearing levels and the tinnitus severity, age was younger for the ISS group. Self-reported hearing levels were worse, and tinnitus severity were worse for the ISS group versus the age-related hearing loss group, and this was statistically significant. This is just a graphic representation of these findings. So we see that The most common self-reported hearing levels for the siderosis group were the severe to profound hearing loss, versus it was predominantly moderate for the age-related hearing loss group, and the prevalence of tinnitus was much greater in the ISS group. So when we looked at the scores, the total scores across the 4 questionnaires, no surprises that they were much worse for the ISS group across all 4 questionnaires as compared to age-related hearing loss group. However, when we controlled for the hearing levels, this was no longer the case for these 2 questionnaires, but remained statistically significantly worse for the ERSA and the tinnitus. We also decided to look at the sub-scores in the specialist domains within the questionnaires to see if there's any difference within those parameters. And we found that the sound localization and sound recognition were actually worse for the siderosis group than for age-related hearing loss group. This is the ERSA questionnaire. Except for personal life, the quality of life, social life, and impact on occupational life were statistically significantly worse for the ISS group than for age-related hearing loss group. And also, the tinnitus functional index results indicated that, except for the cognitive and emotional distress scores, all other parameters were statistically significantly worse for the ISS group. So the key messages are individuals as well as ISS are likely to be younger, are likely to have more severe hearing loss than those with age-related hearing loss. And tinnitus in patients or individuals with ISS is likely to be more prevalent and more severe. And interestingly, the worst scores in the modified Amsterdam inventory domains identified this difference in sound localization and sound recognition. So potentially these may be the distinguishing features of ISS hearing loss as opposed to the age-related hearing loss group. So coming back to my first study, we also saw that there is a diverse auditory vestibular findings in the population or in individuals with superficial siderosis, and retrocochlear involvement is most common when we assess the hearing. Also, evidence of central auditory dysfunction may suggest that there is some proximal extension from the brainstem towards the auditory cortex, and central vestibular involvement in the majority of cases also suggests that the vestibular cerebellum and the brainstem and these pathways are involved before progression to the periphery, to the end organs. So we think that there is this likely antegrade progression of the hearing and a balance loss or dysfunction. And interestingly, the normal findings in some of our patients may suggest that possibly we can pick up the siderosis patients or diagnosed siderosis before the onset of clinical features of ISS, like hearing and balance. So for the clinicians who are joining us here and online, we know that there is no definitive single auditory vestibular test to assess the hearing and balance function in this population group. And we suggest that site of lesion testing approach should be employed for all of the patients with siderosis, and not just that, all patients with complex neurological conditions. And testing of more proximal segments of audiovestibular pathway should be incorporated in the hearing and balance assessment of patients with ISS. And of course, choice of tests and the results would be patient-specific, results interpretation will be patient-specific. And we're looking into this potential value of repeating the assessments over time and how much they vary. So I'm still collecting this data longitudinally, so I hope to have this answer in the next year or so. So a lot of discussion has been on the successes of cochlear implantation, and Professor Werring and we have been approached on several occasions by other clinicians to tell them as to whether to implant or not to implant their patients. I just want to have a brief run over of the literature, scientific literature that's available. So we see there were 3 systematic literature reviews, and 1 was building on the findings of the previous one, and the success rate varies between 46 to 63. But so does the follow-up. So I think this was just 1 patient who had the follow-up for 7 years. But look, median follow-up 12 months, mean follow-up 22 months, which just under 2 years. So we want to know also what's happening long-term with the cochlear implantation. And none of the systematic literature reviews, they referred to the treatment. What treatment did the patients have or were they offered? So the other thing is to consider is when considering cochlear implant for patients is that this MRI usability, because some patients may need to have their MRI done on a regular basis for whatever reason, whatever indication. So you would need to discuss, or patients would need to discuss this with the neurologist or their neurosurgeons, because cochlear implant, even if it's, well, only if it's MRI compatible can be imaged, but this huge artifact, more so on the iron sensitive MRI, this almost creates this effect that renders the MRI images not interpretable. So in our experience, as Professor Werring mentioned, 11 patients have been implanted, and we are currently reviewing the data. But anecdotally, from speaking to patients, I've seen the sustained benefit in those who would have had surgical repair with biochemical evidence of resolution of bleeding. But for others, they say, well, I'm happy to be able to hear environmental sounds and have a more safe life, you know. So essentially aiming for improvement of quality of life rather than improvement in speech scores after the cochlear implantation. And why is this important? Well, because as Professor Werring discussed, apologies, and as we reported in this paper, the quality of life is actually in the boots, as you can see, and we absolutely need to make assessment of quality of life as part of the outcome measure for cochlear implant consideration for patients with superficial siderosis. So on that, I would like to conclude. First and foremost, I would like to thank study participants and their families for their dedication and interest in participating in my studies or our studies, and also the PhD supervisors and the examiners, and also our multidisciplinary team, which I've been a member of since I've joined them. I've started my PhD, and also our incredibly helpful staff, which was scattered around different sites over the years, and of course the funders. So thank you very much for your attention. I think the questions will be after the session, so I hope to answer them then. Thank you.
Thank you so much. As Natallia mentioned, there'll be a Q&A session later today. Plus, just think of this brilliant minds, the men and women in the table in the back left of me, are going to spend a couple hours talking about this tomorrow. What the power of that will be is unimaginable. We're going to take a short 15-minute break. Do what you need to do. There's still coffee and some snacks in the back. We're going to do a quick giveaway. So, is Rory back there still? Where's Rory? All right, we'll do it after the break. Take your break, use the bathrooms. Thank you very much.